Hello, my name is Dr. Andrew Bombach from Columbia University Irving Medical Center in New York. It's my pleasure to moderate today's session, More Options and More to Come, Update on the Management of Lupus Nephritis. We are lucky today to have two amazing speakers on lupus nephritis. They happen to both come from the same institution, from the Ohio State University Wexner Medical Center. And we'll be hearing today from Dr. Samir Parikh and Dr. Brad Rovin. Dr. Parikh will begin by talking about the pathogenesis, diagnosis, and surveillance of lupus nephritis. And then Dr. Rovin will take over and talk about the treatment of lupus nephritis. I don't want to say too much because I don't want to steal any thunder from our speakers, but just to prompt you in terms of what we are about to hear, from Dr. Parikh, we're going to learn how best to use all of the available data that we have in our lupus nephritis patients. And that goes beyond just their clinical parameters to how to use kidney biopsy or kidney biopsies for patients who get repeat biopsies, how to use biomarkers, which is an evolving field. And the idea is we're using these data to better understand in lupus nephritis a number of features that play into the pathogenesis and outcomes of the disease. So how best to understand the role of genetics, how best to understand just how dysregulated the immune system is in our patients, how to formulate the clearest idea of prognosis for our patients, and what are the most important treatment targets we should be focusing on as we manage these patients through their disease course. Then from Dr. Rovin, who has been involved in virtually every major lupus nephritis trial over the last 2 decades. We're going to hear about some of the newer agents that are being used for lupus nephritis. And he will give us some guidance on when and how and maybe even why we should be using drugs like voclosporin, belimumab, and obinutuzumab. And some of these drugs are newer agents of agents that we've used in the past. So voclosporin, a calcineurin inhibitor, but a newer calcineurin inhibitor. Obinutuzumab, a B-cell depleting agent, but a newer one. Some have been around for a while, like belimumab, but just recently we've been able to see very clear data that they specifically help for the nephritis outcomes in lupus nephritis. So we'll hear about when you should use these agents, how you should use them, and how they're actually altering for the better the outcomes for our patients with lupus nephritis. So I think we have an expert panel. We have incredibly important topics, and without any further delay, I'd like to jump right into the talks for today. So I know along with me, you will learn a lot and enjoy these upcoming talks. Thank you.
Hello, everyone. My name is Samir Parikh. I'm a nephrologist at the Ohio State University. I want to thank the ASN for inviting me to participate in this session today, and I'll be focusing our discussion on the pathogenesis, diagnosis, and surveillance of lupus nephritis. We have about 25 minutes, so let's go ahead and get started. You can see my disclosures here, sorry. Research funding from the NIDDK surrounding Aurinia and consulting agreements with Aurinia, Alexion, Bristol Myers Squibb, GlaxoSmithKline, Kaiser Life Sciences. As this audience knows well, lupus nephritis is a common and severe complication of systemic lupus erythematosus. LN occurs in approximately 40 to 50% of patients with lupus. And it occurs early, with first manifestations of LN occurring within the first year of SLE diagnosis in over 50% of patients. And in greater than 80% of cases occurs within the first 5 years of diagnosis. And often lupus nephritis is part of the initial presentation of systemic lupus erythematosus. Lupus nephritis is severe. It is associated with the highest morbidity and mortality in lupus patients. And still in about 10 to 30% of patients will progress to end-stage kidney failure within 15 years of diagnosis. And for patients with proliferative lupus nephritis, about 5 to 25% mortality rate within 5 years of diagnosis. So clearly there's a need for improved management and treatments for LN. The risk of developing LN and the severity of LN seems to be influenced by several factors, including age, gender, and ethnicity and race. And speaking to ethnicity and race, you can see on the top right panel here. This is a study looking at the development of lupus nephritis after a diagnosis of SLE, and they broke it down by race and ethnicity. And you can see that the lowest percentage of developing SLE was, or lupus nephritis, was in white population, where it was significantly higher proportion of patients who were of African ancestry or Black patients, or Hispanic patients develop LN relative to the white population. In another study, looking at severity of LN with a composite outcome of doubling serum creatinine and stage kidney failure death within 3 years of diagnosis. Again, it was the Black population, Hispanic population that had more severe forms of LN and worse outcomes compared to the white population. Now, you may say that some of this is due to socioeconomic factors, and that is certainly true, but that doesn't seem to be the only reason or rationale, and there's a growing body of evidence suggesting there are both genetic and other influences that may be contributing to the worse outcomes in these patient populations. For example, at least clinically, in Black patients with lupus nephritis tend to have more severe disease histology at time of presentation, higher levels of proteinuria and creatinine. They also are more commonly positive for anti-Smith, anti-Ro, anti-ribonucleoprotein antibodies, suggesting potentially a more severe disease course in those patients compared to white patients. And then when we talk about the pathogenesis of lupus nephritis, so certainly the overarching theme here is it's complex, it's heterogeneous, and not completely understood. But recently we've had gaining evidence in genome-wide association studies. And the entirely the thought has always been that there's some genetic susceptibility, and over 80 genes at this point have been genetic variants have been identified to be associated with SLE. And while there aren't large studies looking at lupus nephritis specifically, certainly not in ethnic and racially diverse populations, as LN-specific susceptibility genes have been identified, many of which overlap with lupus, as you can see in this Venn diagram. But there's also a few that seem to be more LN-centric. And I'll highlight a couple here, looking at ApoL1 and Fc gamma receptor 2A. And these two genetic variants of these two particular genes have been associated with lupus nephritis in Black population. And at least in the case of ApoL1, has been associated with more severe disease and poorer outcomes with Black patients with lupus nephritis. But genetic susceptibility alone doesn't lead to overt LN and certainly doesn't lead to organ damage. There needs to be other factors, and the environmental factors, UV light, infection, hormonal changes. These types of things may be that second hit or additional trigger that leads to the presence of SLE clinically. And how does SLE manifest? How does lupus nephritis manifest? Well, it starts with a loss of immune tolerance to nuclear antigens. You get decreased clearance of these nuclear antigens, whether that's because of impaired phagocytosis or a necrotic cell death versus apoptotic cell death. And that leads to the development of immune complex formation. Autoantibodies are circulating. They bind to self-antigens, whether they're in circulation or in tissue beds, like in the kidney. That immune complex generation leads to complement activation, and that complement system can become overwhelmed, and that leads to the low C3, C4 we see systemically. But the immune complexes then can attack organ beds, and what you get is this dysregulated immune amplification. Autoreactive B and T cells are formed. The innate immune system is activated, so you get both activation and dysregulation of the innate immunity and the adaptive immunity. You get maturation of plasmacytoid dendritic cells, release of type 1 interferons, overactivity of autoreactive B and T cells, plasma cells, which perpetuates autoantibody formation, and production of pro-inflammatory cytokines. This recurrent loop leads to persistent and perpetual immune activation, inflammation, specifically in the kidney, intrarenal inflammation, and autoimmunity that, if not checked or remains unchecked, leads to progressive kidney damage or organ damage in the setting of SLE and LN. Clinically, how does this manifest? Well, there's not a lot of advances in this area, despite a whole host of biomarker research and whatnot. It's the same as it's been, although I'll show at the end there is some interesting data and maybe some emerging biomarkers. But clinical manifestations of lupus, as we all know, malar rash, oral ulcers, alopecia, Raynaud's, but also like clinically bone marrow or laboratory identification with bone marrow suppression, leukopenia, anemia, thrombocytopenia. Um, and then when we look at our autoantibodies, in about elevated double-stranded DNA is often associated with, often discussed with lupus nephritis, present about 70% of cases, not specific by any means for LN, but still 30% of patients will not have an elevated double-stranded DNA. There's a lot of discussion about anti-C1q antibodies, and these seem to be more specific for lupus nephritis, but again, only present in about 60% of cases, so not reliably helpful in a clinical setting. Low C3, C4 are pretty commonly seen, of course, not specific for LN, and it can occur in the setting of any lupus flare, but certainly something to look for and trend out in our patients as we monitor them in the course of their nephritis. When we look at kidney-specific manifestations, just by definition, you see proteinuria, because that is hallmark definition of lupus nephritis, but about 50% of patients will have nephrotic syndrome, 80% will have microscopic hematuria, and impaired kidney function can be seen in 60% of patients. And importantly, this can be relatively subtle because most of these patients are young females. Most of their creatinine values are below 1 milligram per deciliter. So the changes in kidney function can be relatively subtle. A creatinine of 1 can be significantly abnormal. And just to kind of have a high index of suspicion, or keep it on your radar that even these mild, subtle changes can reflect a considerable kidney impairment. Urine microscopy is recommended and important, and I'll explain a little bit more details why. But here we're looking at dysmorphic red blood cells. I don't know if you can see them very well, but you can see the dysmorphic red blood cells, acanthocytes, in the top panel on the left, top image on the left, and then red blood cell casts in the bottom image on the left. Highly suggestive active urine sediment, which in the proper context could be concerning for lupus nephritis. And histologically, what are we seeing? So, and I'll show some of the light microscopy images here in a second, but the hallmark here, what's the reflection of this pathophysiology, this regulated immune system, and what do we see in the kidney when we actually do a biopsy? Well, the hallmark finding here is this full house immunofluorescence, where you get polyclonal deposition of IgM, IgG, IgA, and then also, which is suggestive of this immune complex deposition within the kidney. And then activation of classical alternative pathway with C1q representing the classical pathway, and C3 representing classical alternative pathway activation. And you see a bright expression of these antibodies in LN, and having all of them together is suggestive of this full house immunofluorescence that we commonly see in lupus nephritis. And so how do we approach our patients when for evaluation, for further evaluation? So I mentioned the kidney biopsy. So who do we biopsy? So patients who present with lupus, who present with proteinuria levels of greater than 500 milligrams per day, ideally on a 24-hour urine, which is the most accurate measure for measuring proteinuria. First morning void may also be acceptable, but the 24-hour urine is the most accurate measure. Patients who have a nephritic urine sediment, as I mentioned, dysmorphic red blood cells, red blood cell casts, white blood cell casts, especially if combined with evidence of proteinuria, and then decreased kidney function attributable to SLE. In those three scenarios, you may want to consider a kidney biopsy. Kidney biopsy will help distinguish LN from other causes of kidney disease in the setting of lupus, but also give you more a definitive understanding of how the lupus is actually attacking the kidney. For example, and this is based off the ISNRPS, which we'll talk about here in a second. But the way I like to break it down is you have these non-proliferative forms of lupus nephritis and proliferative forms of lupus nephritis. So class 2, class 5 subnephrotic. So these are non-proliferative forms of LN. They tend to have a fairly good disease course, or good prognosis. The class 2 LN, as you can see at the bottom, has mesangial hypercellularity only, and can be treated conservatively or with focus on the extrarenal manifestations of lupus. Whereas the more proliferative forms, class 3, class 4, and mostly class 3, class 4, or mixed class 3, 4 plus 5 with active lesions, these are the patients that you want to treat aggressively. They have the most aggressive course. They have the most poorest prognosis, if not the disease is not controlled. Versus the class 3, 4 chronic lesions, that's where the disease has already happened. The the active injury is already resolved. You have chronic injury patterns that are left. In those cases, a more conservative approach may be recommended. Of course, you want to focus on preventing another relapse, which can lead to more chronicity, as we'll talk about later on in the talk. And then you have the membranous class 5 membranous Um, LN, where you have nephrotic range proteinuria, this you want to focus with immunosuppression as well, as this can lead to poor kidney outcome if left untreated. And certainly the clinical manifestations can be difficult to manage without getting the disease under control. And then lastly, I'll mention that there's in about 5% of cases, you'll get non-LN associated kidney disease in the setting of lupus. And many of these need to be treated differently than how you would treat lupus nephritis. For example, um, lupus podocytopathy, whether it's minimal change phenotype or the FSGS phenotype, may be very steroid responsive. Thrombotic microangiopathy, which can occur due to a number of other underlying conditions associated with lupus, like antiphospholipid syndrome, atypical hemolytic uremic syndrome, or TTP, all have 3 different modes of treatment depending on the cause. Anticoagulation, for example, antiphospholipids, anti-complement therapy in atypical HUS, or plasma exchange rituximab in TTP. And of course, you can get drug-induced or infection-induced kidney injury. So the idea here is that our clinical metrics are not always perfect and are difficult sometimes to distinguish LN from other causes of lupus. The treatment may be variable. So the value of the biopsy comes into play in these scenarios. So what do we do about low-level proteinuria? So the distinguish low-level proteinuria less than 500 milligrams per day. This can be subgrouped into 2 different definitions: silent nephritis and overt nephritis with low-grade proteinuria. I won't spend a lot of time on this, but the idea here is both of these describe patients with lupus who have low-grade proteinuria, but they don't exactly require the same type of management. So silent nephritis here, no urine abnormalities, low-grade proteinuria less than 500 milligrams a day. Overt nephritis with low-grade proteinuria, this is low-grade proteinuria with evidence of glomerular hematuria or active urine sediment. And it turns out that, and I'm not showing the data here, but in silent nephritis, and these have been studied actually back in the 80s and 90s and again in the 2000s, if you have silent nephritis, no urine abnormalities, low-grade proteinuria, most of those patients are going to have a class 2 or earlier lesion or even no evidence of immune complex deposition in the kidney. Compare that with patients who have overt nephritis with low-level proteinuria. Here's 2 studies kind of highlighting that. The first one on the top is 38 patients with SLE. All of them had glomerular hematuria and proteinuria less than 500 milligrams per day. This was all their first biopsies. And what you found was that 86% of patients had a proliferative form of lupus nephritis. In a more recent study of 222 patients, all of which had proteinuria and glomerular hematuria, they're stratified with proteinuria less than 5.5 grams per day versus proteinuria greater than or equal to 0.5 grams per day. And what you found expectedly, 96% of patients with proteinuria greater than or equal to 0.5 grams per day had a proliferative form of lupus nephritis. But strikingly, the patients with less than 0.5 grams per day, and similarly to the first study, 84% of those patients had a proliferative form of lupus nephritis. Going back to the point is when we go through our diagnostic tree, if patients have an active urine sediment, even with low levels of proteinuria, a biopsy should be considered because there may be a high likelihood that they have a proliferative form of lupus nephritis. So speaking on the classification of LN, and I'm not a pathologist and I'm not going to go into too much detail here, but I just want to highlight the 2018 revisions to the ISNRPS that hopefully will allow us to reduce variability and understand better how we can use the lesions that we're identifying in histology to kind of help prognosticate and inform on treatment. So the ISNRPS, you can see to the left, we all probably know very well, but some of the limitations of this is it wasn't exactly informative when in terms of prognosis or even informing on treatment. At least that's some of the criticisms. Did not routinely consider tubular interstitial or vascular lesions. It did not routinely recommend quantification of activity and chronicity indexes, and descriptive categories lack clear prognostic value. Now, fast forward to the 2018 revisions. This is by the working group, and they ISNRPS working group, and they recommended terminology changes to simplify and improve clarity. For example, removing the term endocapillary proliferation to endocapillary hypercellularity, for example. They also recommended routine use of the semi-quantitative scoring for activity index, chronicity index, and had a renewed emphasis on determining the value of TI and vascular lesions in LN. The whole hopes of all this was to reduce variability in reporting and determine the value of these histologic metrics. And I'll highlight the rationale behind some of this when we look at repeat kidney biopsies. For activity index and chronicity index, you can see the scoring here. It's out of 24 for activity index and out of 12 for chronicity index, with both tubular interstitial and glomerular features involved. So let's move on and talk more about the goals of LN therapy. So of course, when a patient presents to us with LN, we talk about trying to induce a remission or a clinical response, and that's very important to this journey. But ultimately, we want to preserve long-term kidney function. That is our ultimate goal, and we do this obviously to preserve kidney function, and in with that vein, to limit the complications associated with chronic kidney damage, in particular cardiovascular complications, which we know our patients with SLE are already at high risk for, and the CKD burden will just add to that risk. And you can see on this figure, this nice graphic from Anders and Rovin, Kidney International 2016, showing with initial flare, you get significant chronic damage and nephron loss. But if you're able to attenuate that flare, you could see nephron loss kind of paralleling that with what you see with aging. However, if you cannot control the disease, you get the kidney loss or nephron loss continues at a much higher rate, a greater degree, leading to end-stage kidney failure um, uh, many years before that in patients who are controlled. So when we talk about, again, maintaining long-term kidney health, we have to start with remission. And what does remission mean? And so this is a study done of 86 patients back in 2008, looking at patients with proliferative lupus nephritis and longer-term outcomes. So what they found was that patients who achieved a complete renal response within 5 years of study entry, 92% of those patients were dialysis free at 10 years of follow-up. So they were doing, compare this to the partial responders. Only 43% of these patients achieved remained dialysis free at 10 years follow-up. It's a pretty striking difference between complete responders and partial responders. And of course, non-responders did very poorly. Only 13% were dialysis free. And even in this study, they used 0.33 as their cutoff in terms of grams per day for proteinuria. And within 5 years of study entry is their criteria for clinical response. And you can see the difference in outcomes between complete responders and partial responders, highlighting the importance of a complete clinical response for treating our patients with LN. But what is the definition of response? So if you look at the guidelines, whether it's KDIGO, EULAR 2019, they use proteinuria less than 0.5 grams per day cutoff, and that might be right, but there's two studies that kind of point against that, maybe that we're a little bit too strict with our proteinuria cutoff criteria. And this is retrospective analyses of larger LN cohorts that were prospectively collected data. The first one to the left, you can see done by Maria Delara's group, looked at the Eurolupus cohort, 76 patients, and what they found was that proteinuria level of less than 0.8 grams per day was the best predictor of good long-term renal outcomes. And that was not improved when you added hematuria or serum creatinine. So proteinuria at 12 months, this is after 12 months of treatment, proteinuria was the best marker of good long-term outcomes with 7 years of follow-up. In another study, the MAINTAIN LN cohort, 90 patients, this was done by Tamaroon colleagues, found the same thing, pretty similar results, proteinuria of less than 0.7 grams per day, best predicted good long-term renal outcomes, had the highest sensitivity and specificity for good long-term renal outcomes, again, 7-year follow-up, suggesting that maybe we don't need to be as strict with our proteinuria cutoff criteria. So what about looking at renal relapse? And so renal relapses are common in LN. Relapse of LN occurs in approximately 30 to 40% of patients overall and associated with poor outcomes. In a study of 48 patients who were induced with CYC, for example, cyclophosphamide, for example, median time to relapse was about 36 months with 25% relapse rate within the first 5 years of diagnosis and 46% relapse rate within 10 years of diagnosis. In a study that we did, looking at, and this was using the Ohio SLE study. So this is a longer term follow-up of patients who had routine blood and urine collections done every couple months. And what we found was that patients who, we looked for risk factors for development of chronic kidney damage. And what we found was in these 56 patients, the duration of time spent in LN flare was associated with a 20-fold increased risk of developing progressive CKD. So if we spent greater than 30% of time in LN flare, your risk for developing CKD was 20-fold higher than those who spent less than 30% time in LN flare. Of course, just suggesting the importance of not only attenuating a remission or clinical response, but maintaining that response. And just to highlight that point, this is a study looking at patients, and basically they stratified them by achieving a complete clinical remission and then sustaining that remission for greater than 5 years versus less than 5 years. And what they found across the board when it came to chronic kidney damage, doubling serum creatinine, damage index, or death, the hazard ratios favored those patients who had sustained remission for greater than or equal 5 years. They had significantly better outcomes than those who had remission for less than 5 years and then subsequently flared. Now, when we talk about maintaining remission, part of that discussion that we have with our patients in clinic is how long do we treat for? The problem with LN and SLE is that it's not a curable disease. It's a disease that relapses at any point in time with non-predictable triggers. So, but general recommendations are if you can have disease control for 18 months or 3 years, depending on which guideline you're looking at, you may be able to consider taking your patients off therapy or weaning therapy. But that's based on experience based. That's not based on evidence, as there's no good guidance based on evidence in terms of how to withdraw therapy. So recently, there's been some interest in looking at kidney biopsies, repeat kidney biopsies after prolonged maintenance, determine who can come off therapy. In this study of initially 56 patients, but ultimately 36 patients who underwent repeat kidney biopsy, all these patients had complete clinical remission for greater than 12 months, on maintenance therapy for greater than 30 months. And what they found, and what they did was these patients underwent repeat kidney biopsy, and they all came off therapy and they were followed for 2 years. And from this study, what they found was that patients who had overall 44% of patients at repeat biopsy, despite complete clinical response, had evidence of histologic activity. This is consistent with other therapies that demonstrated the clinical and histologic discordance between in LN. And overall, there were 11 flares, and 9 patients of the 11 had an activity index of 2 or higher. And importantly, those patients had activity index of 0, which were many. Only 1 patient had a flare after this 2-year follow-up. This suggests that perhaps patients that activity index of 2 or higher is associated higher risk for flare, and those patients who have immunologic or histologic remission may be able to safely come off therapy and prevent them from being exposed to undue and excessive toxicity from immunosuppression. This is another study of 42 patients with proliferative LN, all underwent repeat kidney biopsy by protocol at 24 months after the first biopsy. And in this study, an activity index at repeat biopsy of greater than 3, as is circled here, was associated and predicted renal flare. Additionally, a chronicity index at repeat biopsy predicted a poor kidney prognosis. And so all of this suggests that maybe we can utilize a repeat kidney biopsy as a tool to kind of help us determine who may or may not be able to come off biopsy or come off immunosuppression. Of course, this is not completely non-invasive. It can be done. It can be done safely, but it's not invasive. It is invasive, and certainly it would be nice to see this kind of study done in a larger, multi-centered prospective study to kind of help determine the value of this repeat kidney biopsy and see if these findings actually hold true. Ideally, though, we would identify non-invasive biomarkers that better allow us to identify flares and prognosticate and predict treatment response for our patients. This is one such biomarker, CD163, is a macrophage dendritic cell marker that was previously shown to correlate with disease activity in ANCA-associated vasculitis. There was a study here done by Mejia Villay and colleagues where they, and some from our group, that looked at soluble urine CD163 in 2 different cross-sectional cohorts, a Mexican cohort and OSU cohort, where the measures were done at biopsy, and then longitudinal cohort and Mexican cohort, as well as an OSU Ohio SLE study. And what they found was that urine CD163 correlated with clinical and histologic markers of disease severity. As you can see in the bottom left dot plot, that the higher levels of CD163 were with proliferative forms of lupus nephritis. It seemed to predict clinical response. As you can see in these 2 figures here, in both settings, you can see the CD163 levels coming down and becoming and dropping down to less than 370 nanograms per millimole within three months of treatment in patients who went on to develop a complete clinical response. And the levels were different significantly between complete responders, partial responders, and non-responders. And it held true in the Ohio SLE cohort, where they looked again, found that the levels started to rise before flare, actually, before the diagnosis of flare, and importantly reduced in complete responders and partial responders, but stayed elevated in non-responders, suggesting maybe this is even a prognostic marker for LN. So with that, I'll conclude by saying the pathogenesis of LN is complex, heterogeneous, and incompletely understood. This all contributes to the heterogeneity in presentation and treatment response, and hopefully in the future, combining histology with molecular biology may be able to help us identify and maybe more personalize our therapies and improve our response rates. The kidney biopsy remains the gold standard for LN diagnosis. The revised classification schema may be more informative for diagnosis and prognosis, but even at low levels of proteinuria, severe LN is possible, and a biopsy should be considered in patients who have active urine sediment even with low level proteinuria. Flare prevention is critical to preserve long-term kidney health. Maintaining good long-term disease control portends a better prognosis. Activity index at repeat kidney biopsy after prolonged treatment may help risk stratify patients for flare and need for continued treatment. And moving forward, obviously the holy grail is promising urine biomarkers or biomarkers, serum urine biomarkers, non-invasive biomarkers. They are emerging, and I showed you one example. There's several others, and while they need validation, they may soon be able to be applied in clinical practice. And with that, I'll end, and I'm happy to take any questions. Thanks for your time.
Hello, everyone. I'm Brad Roven, and I'm pleased to talk to you today about new options for the treatment of lupus nephritis 2021. These are my disclosures, and just for transparency, I have worked on the advisory board of the pharma companies that have produced both of the medications I'll be discussing today. So, I'd like to just put into perspective where we are now with the treatment of lupus nephritis. The FDA has recently approved both voclosporin and belimumab for the treatment of active lupus nephritis. We know that adding voclosporin or belimumab to background immunosuppression significantly increases the number of complete lupus nephritis responses at 1 or 2 years. These are the data on which this conclusion is based. On the left are the data from belimumab, and as you can see, two different endpoints were used. The primary endpoint was called PERR, primary efficacy renal response, and this is similar to what we think of as a complete renal response with somewhat relaxed criteria for GFR and for proteinuria, and this endpoint was examined at 2 years. The major secondary endpoint of the trial was complete renal response, which was traditional less than 500 milligrams of proteinuria per day, and a GFR that could be no more than 10% different than the baseline GFR. And as you can see, in the belimumab group for both PERR and CRR, there was a significant increase in the number of patients having a complete renal response at 2 years. On the right side is are the data from the voclosporin trials, and this is a combination of data from both the phase 2 and the phase 3 trials, and you can see that as early as 6 months there was a significant increase in the number of patients having a complete renal response in the voclosporin arm of the trial, and this increased at 1 year and remained highly statistically significant. We also know that adding these medications to background therapy can be done safely. These are the adverse event profiles of patients receiving belimumab or placebo on the left side and patients receiving voclosporin or placebo on the right side. And as you can see, these adverse event profiles are very similar between the placebo and the active drug arm. Now, we all know that achieving a complete renal response should lead to better preservation of kidney function over the long term. I'll show you some older data, but they're still relevant. And as you can see here, this is kidney survival in patients with lupus nephritis, divided into those who have achieved a complete renal response, a partial renal response, or no response. And you can see that achieving a complete renal response is clearly superior to no response and superior as well to a partial response. So we could simply say treat everyone with background immunosuppression. And for these trials, background immunosuppression was mycophenolate plus glucocorticoids or low-dose cyclophosphamide plus glucocorticoids, and add either belimumab or voclosporin to the regimen. But there's some things to think about. Which drug should we use? We have no biomarkers to identify who would benefit most from belimumab or who would benefit most from voclosporin. These new medications don't really reduce the immunosuppression burden for lupus nephritis patients. And while adding them to background therapy is safe in the short term, long-term safety data in this population of lupus nephritis patients are lacking. Adding to the background therapy increases the pill burden or the polypharmacy for patients who already have significant or important adherence issues. These medications are costly, and this may be a barrier for many patients. And finally, in both trials, a significant proportion of patients did respond to background therapy alone. So I'd like to propose one way to think about using belimumab and voclosporin currently. So we start with a patient with lupus nephritis. And let me just bring the pointer up. Okay, so we start with a patient with lupus nephritis. Give them a modest dose of intravenous glucocorticoid, and then start the patient on either mycophenolate or urolupus cyclophosphamide, as we currently do, using a modest dose of oral corticosteroid. Follow the patient closely for the first 2 or 3 months and look for an indicator or a biomarker that the patient is responding to therapy and will do well on what you're giving them now. And I suggest looking for stability or improving kidney function and a decrease in baseline proteinuria of at least 25%. There are some studies, albeit observational, that suggest early reduction of proteinuria of this magnitude actually portends response at 6 months and later. If the patient does meet these metrics, it would be safe to continue the current background immunosuppression and then finish the treatment as one would do in the case of usual treatment. However, if the patient is not showing an improvement or the improvement is not up to this level of proteinuria reduction, then consider adding either voclosporin to mycophenolate or belimumab to mycophenolate or urolupus cyclophosphamide. Again, I think it would be prudent to follow the patient closely for 2 or 3 months and then assess the same metric. In other words, is the patient now showing a reduction of proteinuria by at least 25%, and is the GFR improving or at least stabilizing? If the answer is yes, then the patient will receive or finish the regimen they're on and then have long-term lower dose maintenance therapy. If not, and you verify adherence, then the patient might have to be considered for treatment for resistant disease, which is beyond the scope of today's discussion. So this still doesn't really tell us whether to choose belimumab or voclosporin. And when we do a deep dive into the data from the clinical trials, I think we can start to differentiate these two therapies. Glucocorticoids are used for all lupus nephritis patients, are uniformly disliked by patients, and have a litany of short and long-term adverse events. In both voclosporin trials, a unique glucocorticoid taper was used. The patients were started on a modest dose of intravenous methylprednisolone, and then this was followed by the taper shown in the figure. Oral prednisone was started at 20 to 25 milligrams a day, and as you can see, the dose was tapered very quickly. over the first 12 to 16 weeks, and then the patients were maintained on a low dose of prednisone. This combination of voclosporin and mycophenolate, given with low-dose rapidly tapered glucocorticoids, is likely to improve patient adherence and reduce short and long-term adverse events. Subgroup analysis of the voclosporin trial is also informative. So the subgroup analysis included an analysis by ancestry, and as you can see in patients of Asian ancestry, African ancestry, and other than Caucasian, voclosporin was effective. The same was true for patients both of Hispanic and non-Hispanic ethnicity. In terms of looking at the response by biopsy class, you can see that there was a trend for an improvement in the patients with pure class 5 lupus nephritis who received voclosporin, but this did not quite reach statistical significance. As a caveat, the number of patients in the voclosporin trials that had pure class 5 was a small number. Because voclosporin is a calcineurin inhibitor, we found that the probability of reaching a urine protein to creatinine ratio of less than 0.5, so less than 500 milligrams of proteinuria a day, occurred very rapidly in the patients receiving voclosporin. And as you can see, the curve separated quickly within a matter of days, and that separation increased over time. The rapid reduction of proteinuria during treatment with voclosporin was most likely due to both hemodynamic effects of the calcineurin inhibitor as well as a direct effect of the calcineurin inhibitor on damaged podocytes. Calcineurin, of course, mediates the dephosphorylation of synaptopodin, making it susceptible to degradation by cathepsin. Synaptopodin is critical for stabilizing the actin cytoskeleton, and of course, by blocking calcineurin, calcineurin inhibitors protect synaptopodin and the cytoskeleton. And of course, in turn, podocytes appear to protect the glomeruli. As you can see here, GFR is a function of a good podocyte number. As the number of podocytes decrease, GFR falls, and concomitantly, glomerulosclerosis actually increases as the number of podocytes decline. So the rapid reduction of proteinuria may actually be protective additionally for the tubular interstitium by reducing interstitial inflammation that occurs in the presence of proteinuria. And the preservation of podocyte integrity may translate over to better long-term maintenance of kidney function. We can do a similar deep dive into the BLISS-LN trial. And so what I'd like to do is show you the subgroup data from the BLISS trial. So patients were divided by the standard of care regimen used. The BLISS-LN trial was unique in many respects, and one of which is that the PI at each site was allowed to choose whether the patients were treated with mycophenolate for background therapy followed by mycophenolate for maintenance, or urolupus cyclophosphamide followed by azathioprine. And what you can see here, looking at the mycophenolate group and the overall response for both the PERR and the CRR, the overall response was really driven by the patients that had received mycophenolate as background therapy. The patients who had received cyclophosphamide as background therapy did not have a statistically a greater number of patients achieving either response endpoint. In terms of class, you can see that class 3 or 4, so proliferative lupus nephritis, really drove both the PERR response and the CRR response. There was favorable, but still not statistically significant improvement favoring belimumab if proliferative lupus nephritis also had a class 5 component, but you can see that for pure class 5, there was no advantage to patients being treated with belimumab. The same caveat applies as with the voclosporin trial. This study was not powered to look at subclasses, and of course, the number of pure class 5 patients was small compared to the total number of patients. When patients were divided into baseline proteinuria level and simply low versus high, low proteinuria was less than 3 grams per day and high proteinuria was 3 or more grams per day, you can see that the response favoring belimumab was driven by the patients with low proteinuria, both for PERR and CRR. Patients with high level of proteinuria did not show a statistically significant increase in complete responses. Now, the effect of belimumab on lupus nephritis flare during this two-year trial was significant. As you can see here, overall, there were fewer lupus nephritis flares in the belimumab group. This didn't matter whether the patient was receiving cyclophosphamide or mycophenolate as background therapy. It was again favorable in proliferative lupus nephritis, but also the trend was quite good for patients with either mixed or pure class 5 lupus nephritis. The effect of belimumab on kidney function was also determined looking at eGFR slope. And if you just look at the boxed data, these are patients on treatment, either placebo or belimumab, and these are patients who remained in the study but may have stopped their treatment with the study drug. You can see that all the patients had a negative eGFR slope, suggesting some loss of GFR over the study. But you can also see that in the patients who were receiving belimumab, no matter which, whether they were on treatment or on study, the trend was a significantly lower loss of GFR slope over time than the patients in the placebo group. This was also mimicked by looking at the effect of a sustained decrease in kidney function of either 30% or 40%. And again, if you look at the data, focus on the red boxes. These are the number and percent of patients in the placebo group or the belimumab group who had a sustained 30% fall in GFR and a sustained 40% fall in GFR. And as you can see, there were significantly fewer patients who achieved these declines in GFR in the belimumab treated group. So I want to show you the same schema that I showed at the beginning, but put these secondary analyses into the scheme to help inform us a little bit better on how to use the new therapies. So the first thing is I've added the word proliferative here to lupus nephritis because neither drug showed especially impressive results for patients with class 5 lupus nephritis. The rest of the scheme is the same as before, but when we get now to differentiating between the two new therapies, I've added the caveat that belimumab may be best used in patients with less than 3 grams of proteinuria per day, and that background therapy of MMF should be a consideration for the addition of belimumab. Now, I do want to also suggest some other caveats. It looks like from the secondary analysis that belimumab may be effective in preventing flares of lupus nephritis, which take their toll on renal function over time. So impaired GFR and the need to avoid lupus nephritis flare, especially in patients that have started progressing towards end-stage kidney disease, belimumab may be the appropriate choice. On the other hand, in patients needing a rapid reduction in proteinuria and also where we're concerned about podocyte health, voclosporin may be a reasonable choice. I'd like to make one final comment. At the end of both trials, over half of the lupus nephritis patients in each trial had not achieved CRR or PERR in the case of the belimumab trial. We still need investment in new medications for lupus nephritis, and the search continues. And just to end, this is a table that I put together that shows several, it's not comprehensive, but several of the therapies that are being trialed for lupus nephritis at the present time, and the various targets. So we're targeting the complement system, interferon, cytokines, co-stimulatory pathways, and the immunoproteasome. So there are definitely more advances to come in the treatment of lupus nephritis. The landscape looks very exciting, and I think we should be quite encouraged by both the results that we've seen and the results to come. Thank you very much.